So the next case I'd like to show is at the other end of the spectrum. This is an older adult, a lady in her 50s with a previous AF ablation. After that ablation had occurred, during which actually a septal puncture was performed separate to the atrial septal defect that she had, the referring team were unable to close her defect with an Amplatzer septal occluder. They just couldn't get the defect to conform, and then the defect looked as if it had prolapsed on several occasions. Therefore, she was referred to our team for ASD closure. So 78 kilograms, 55-year-old lady, relatively well, with resolution of arrhythmic symptoms and echo evidence of an indication for closure with right heart dilation and some exercise intolerance. She had what we could see on echo, a 17 millimeter single defect. There were some suggestions of a fenestration in the posterior portion of the septum, thought to be iatrogenic after the ablation procedure. However, we didn't really see that very well. Her aortic rim again was deficient. Now, as with many adults, her primum septum is thin and her secundum septum she had nice, thick, chunky secundum septal margins. So again, with experience here with 3D transesophageal echo, I didn't use a sizing balloon, but again, I would suggest that particularly early in experience that one follows the IFU and uses a sizing balloon to determine appropriate device sizing. So here you can see what I mean. The primum septum in this lady's case, really rather thin, but a good sort of chunky secundum septum rim, which as we sweep through here, you can see is deficient at the aorta, but really otherwise pretty good rims. So as you go here in this, from SEC to aorta, you can see the sort of primum septum deficiency, but a good chunk of secundum septum, and a defect that's really in the 1.5 centimeter range. Now, often you see this with 3D TE, that if you under render the 3D imaging, you'll think that it's an enormous hole, but in this case, the primum septum just was very thin and very easy to under render with transesophageal echo. So you see here that the inferior and inferior anterior rim was really not well delineated by 3D, but the actual defect is what we can see here, this very oval shaped defect above this thin primum septum that extended down inferiorly. So this is the defect here, and measured, I think, about 17 by 13 millimeters. There we go. In fact, 17 by 10 millimeters. And again, previously the team had tried a 26 millimeter Amplatzer ASD occluder and also a 30 millimeter Gore GSO device. Very different device to the Gore cardioform ASD device, but that was what was available to the team trying to close the defect in the first place. So part of the reason for referral to our center was because of our expertise and the availability of the cardioform ASD device to us. So you can see again, the SEC rim, large, this thick secundum septum, but anteriorly a bit deficient as you head towards the aorta, and then this very thin primum septum in the inferior portion of the defect. Again, for that reason, the suspicion about the perforation that we couldn't see, but sort of the perforation in the posterior septum that we couldn't see. Also the fact that the septal length was very large, that this is an older adult, and that we definitely on 3D had got 17 millimeters in one plane. That would suggest that with balloon sizing that we may have ended up with a defect that was in the IFU range for a 37 millimeter device. So again, I elected here to go for the 37 millimeter GCA. And here you see, just with good 3D echo imaging, you can see the funnel of the device opening up in the left plane here. And with an adult, if you've got enough space to manipulate the TE probe back and forth in the esophagus, you can get this nice picture of the left side of the device opening up in the left atrium. And corresponding to that, you can see some fluoroscopy here of the device opening up, showing that nice funnel or tulip-shaped extrusion of the device in the left atrium that allows you to know that you've got the device fully open, ready to pull back onto the septum. So on the right here with the 3DT, you can see quite nicely the formed up left side of the device being brought back and jumping into place on the left side of the atrial septum. Just there, you can see the device bedding down on the left side. And that allows you in most patients to give quite a bit of tactile tension onto the septum with the left atrial disc before, as you can see in the fluoroscopy on the right, before deploying the right portion of the device. And you can see here that at the end of the fluoro run here, one can see the right disc forming up, and then the gap between the right disc and the left disc suggesting splaying across that thicker secundum septum. So just here as the device forms up, you can see some nice splay between the right and left portion of the device. Again, just to show that, so that you can see the sort of cupping of the left disc as you put tension on the septum. So you pull it down onto the septum, so down onto the septum and then cupping. And next, you can now see the right side of the device being pushed out. And then as you come onto the septum, you can see that splay, which in this particular case is really towards you in the plane of the fluoroscopy. You can see the separation of the left and right disc. I think this is a good example of before locking the device. So you can see, although there is device on the left side of the septum here and on the right side of the septum, and this is sort of a bicable view really showing the SVC portion. But although there is clearly device on either side and there's no significant residual leak, the orientation of the device still looks strange, and that's because this is before the device is locked. So you'll see here again, you can see the locking loop within the deployment catheter here. And as the device locks, you'll see that popping out and forming a loop here. So again, if you just look towards the end of this video, I can briefly pause it when that loop forms up, and you'll be able to identify that loop in this case. Oops, jumped on ahead, let me just go back. So here you can make out the locking loop, which is that straight piece of wire that was within the catheter, but after release, it loops up like a pigtail and allows the two sides of the device to be pulled together. After locking, you can see the device flattens out almost immediately. Now the left side of the device is much more obvious with the device over here. This is the secundum septum in the area of the SCC, and you can see a much more appropriate alignment of the device after locking. Very commonly, towards the mitral valve, you'll see the disc lifting off the atrial septum a little bit. This is something, again, you see resolving over the weeks and months afterwards, but you often see this the portion of the device just sitting proud of the secundum septum at the area of the AV valves. And again, no interference or damage to the mitral valve, and just a little bit of the petals of the disc just raised up off the septum here in a freshly deployed device. And I think what this shows is just after after the suture, which is your security blanket for being able to unlock and retrieve the device if you're not happy with the way it looks. As the suture is released or withdrawn away from the device, you can see that the catheter moves away because the device is now totally free. And then you see the delivery system being withdrawn down towards the IVC. So after locking, minimal movement of the device when the suture is released, and then the delivery system can be withdrawn into the IVC. And then I think it's important after locking, or certainly after complete deployment, just watching, taking an on-fast and a side-on view of the device. This is normally seen with an RAO caudal view, and then an extreme LAO view will show the device side-on. And I quite like this, both to see the locking loop passing through, and intermittently frame to frame, you can see the wire passing through the center of the device and hooking around here, showing you've got the device locking loop captured. And again, this distribution of the petals suggesting that you haven't entrapped any cardiac tissue. I think is quite reassuring as well. So in this patient, the atrial septal length was large, but with a history of arrhythmia, I wanted to make sure that if possible, we didn't cover the entire septum. This would mean that there would be septum outside the margins of the device that could be used for transseptal puncture if and when this lady's atrial fibrillation or another arrhythmia occurred. So that's just something to think about. I don't think it should be one's primary thought process or device sizing, but it's always nice if there's native tissue beside the device that could be punctured in future. The floppy IVC room, as well as the availability of space and the slightly deficient aortic rim, meant that we went for a 37mm device rather than a 32mm device. And I think with these adult patients with firmer secundum septums, although you do get a rotation, a positional alteration of the device with locking, it's not as dramatic as you see in the younger children.